when we're talking about better outcomes, like with IO, their approvals were based on response of about 15 to 16%, right? But response in liver cancer is never really correlated with outcomes. So what is different about the response with IO as compared to ramucirumab or the TKIs?
I mean, I would say the easy way to answer that question is by saying that the durability of these responses, the depth and durability of the responses can be certainly a distinguishing characteristics of IO agents. The challenge, as you said, it's ultimately a minority of patients who achieve these deep, long-lasting responses. And one of our challenges, how do we increase that percentage? How do we get more patients to have deep, long-lasting responses?
Yeah, that's a great introduction to a final thought as we're thinking about the future. How do we increase those responses? You know, I know there's been great interest in other diseases and immunology. Obviously, there hasn't been mature data in liver cancer, but PD-1 inhibitors plus CTLA-4 inhibitors, right? And in liver cancer, there's some theoretical concerns about toxicity. And there is an arm in the 040 study evaluating that, and we look forward to hearing data in the future. But as we sit here today, there is some data. There's the combination of bevacizumab and atezolizumab and lenvatinib and pembro. And what's your take on these data sets and where they're going?
So these are early data sets that are evolving, mostly in a phase 1b type setting. But to be specific with the atezo-bev, most recently shared data at ESMO 2018. The independently reviewed response rate was around 27%. The investigator-assessed response rate was around 32%. So roughly we could say 30% response rate safely. So in theory, that could mean doubling from 15 to 30%. So that's intriguing and promising with a reasonable safety profile. Similarly,
and I think they got a breakthrough therapy designation based on that, right?
Correct. Similarly, for the pembrolizumab-lenvatinib combination, where the confirmed response rate was just below 30%. So again, another promising signal. So these are ways of combining quote-unquote anti-angiogenic therapy with anti-PD-1 therapy based on some scientific rationale that seems to be showing promise. IO combinations, as you alluded to, are another way that I think we're gonna see attempts to hopefully improve
the Himalaya study is a phase 3 study already launched, right, of durvalumab and tremelimumab, right, in advanced liver cancer based on, you know, a small subset, but also extrapolating from other diseases with bevacizumab and atezolizumab. I think that regimen shows a lot of activity in lung cancer, right? So it's partly building on what we know about in liver cancer and then probably extrapolating also from other diseases.
But it brings up one important thought, right, is that this is still an area that's evolving, and I think commitment of all physicians to enrolling patients onto clinical trials is absolutely critical.
For sure.
There are a lot of studies, a lot of investigations going on, and these patients are across the world with many practitioners, and I think being conscientious about diverting the right patients to the right trials is going to be important.
Yeah, so with that thought, as we come to the close, I mean, there are a lot of agents available for patients. That's fantastic. I think over time we're going to see that sequencing these, we are improving survival for advanced liver cancer, right? This disease now has more options and I would argue a better outcome than pancreatic cancer, right? And we've moved very fast in a short period of time. And even though there's these options, there's always room for improvement. And I think referring patients to clinical studies, as self-serving as that is, us being an academics, I think it's best for the field and best for patients. So with that in mind, this has been an excellent discussion, Anthony. Next time we'll talk about USC football and basketball and UCLA and their rivalry, but not in liver cancer. We hope that you found the information presented in this webinar to be valuable to your clinical practice. Thank you for watching OncLive News Network.